It has so many different aspects to it, and certainly I'll be talking about vision today. And but you really do need a big team of people that understand nutrition, people that understand physiology, orthopedics even, and it's a huge influence on everyone's life. I mean, those that have had concussion certainly find it challenging to share with others, even their loved ones, what it's like to have a concussion. And let alone describe that they even have symptoms at all, because you look normal in so many ways, but it's so difficult to work through these symptoms, and to have an understanding group such as Beyond Concussion to share ideas, to consult with, and to really support each other is something that I think is absolutely critical. So thanks for being here for everybody, Beyond Concussion, and everyone that's involved in it. So, and vision is a highly misunderstood field. So many people feel that 20/20 eyesight is what vision is all about. And so as a rehabilitative optometrist, I think it's very important to establish some definitions. So let's talk about vision itself. The definition of vision is a umbrella term that involves being able to receive light, derive meaning from light in the environment, then to make an action in response to that light. Now, that's a very broad definition, but visual acuity, that is 20/20 eyesight, is one very small part of that. But the other parts of vision include eye movement control, focusing ability, peripheral vision, visually guided movement, visual thinking, and visual processing, and visual perception as well. So all of these other aspects of vision are really the areas where you have problems when you have a concussion. Visual acuity is rarely an issue, but more often there's issues with these other areas, like I mentioned, the eye movement control, binocularity, focusing, peripheral vision, the ability to contend with bright light, for example, and kinetic movement in your environment, and certainly the ability to visually guide your movement through space as it engages the vestibular system especially. So balance and coordination are often affected. So it goes far beyond just 20/20. So we're going to talk about those other issues that surround vision, not just visual acuity. So, and let's advance this slide here. So when you go to a vision physician, you want to make sure that they are specializing in the area that you need help with. So a rehabilitative optometrist, a neuro-ophthalmologist are often the two key places to go. Now, a neuro-ophthalmologist would be one if you do in fact have a lesion in the brain that is identified through imaging, such as an MRI or a VER or VEP, which are subspecialties of EEGs. So if you've had some brain imagery or some electrodiagnostic testing of your visual system, or if you need that, a neuro-ophthalmologist is the place to go, because they have the equipment. Usually it's at a hospital setting, and they can come up with lots of good information about any organic disruption within the brain. But you should also realize, and I'm sure most of you do, that when you do have a concussion, many of these neuroimaging techniques do not reveal the underlying damage that is in fact there. So there is organic damage that can't be picked up by MRIs, even sometimes functional MRIs, where they're monitoring the blood flow and the glucose oxygen level of the brain in various parts of the brain. So even with those subtle imaging techniques, sometimes the actual biological effects of a concussion they're not able to be visualized by a clinician. So a neurorehabilitative optometrist looks at the functional skills that have been disrupted from a concussion. And it's unbelievable how often people with concussions have visual problems. And 2/3 of all the nerves that come into the brain originate from our eyes. And about that same amount of individuals that have a concussion have visual symptoms. And that kind of makes sense. And you can see that in this image of the brain. So vision occurs in our brain. It doesn't occur in the eyes at all. So the eyes are very rarely injured in a concussion. It's the visual system. And you can see that green area in the back of the occipital lobe is where light originally goes to in order to be perceived by the individual. And these pathways then feed forward to the superior part of the brain, or the dorsal part of the brain, which is the where pathway. That's the part of the visual system that tells us where things are. And then the ventral pathway tells us what things are. And this coordination of events, of knowing where things are, knowing what things are, is routinely disrupted in a concussion, especially to the type of concussion that's similar to whiplash. So when the head moves forward and back, the brain is oscillating inside the skull, and there's shearing that occurs of the neurons that provide these pathways that are in integrity. So when these pathways are out of synchrony, it's very difficult to know when and where things are happening around you in a consistent, reliable way. And then it makes it also very difficult to interpret what it is that you're seeing. So some of these symptoms that are occurring in concussion, as many of us have, the blurred vision, not because of the inability of a refractive condition change, but the accommodative system. That is the system that we use to cause things to be clear close up. So regulating the muscle inside the eye is what needs to be done. It's not the organic capacity to see clearly, but it's the physiological ability for the eyes to mobilize the muscles sufficiently well to maintain and control the focusing system. And that's why there's a blur. And there's photophobia, because photophobia is when you have an aversion to light, or to flickering light or bright light, fluorescent lights. Fluorescent lights are typically very difficult for people with concussion. And this is thought to be because there's a lack of inhibition to the visual pathways before they reach the cortex. So 90% of the nerves in the brain, they go to the thalamus, the middle of the brain, and they actually block most of the visual input that arrives from the eyes, so that all of it doesn't reach our brain. Because if all of that information reached our brain, we'd be overwhelmed. And this is what's happening with photophobia. We don't have that natural control over the information that seems to be coming in from the eyes and then flooding into the cortex for awareness. And the same thing with auditory, by the way. So many times with concussion, sounds are incredibly difficult to contend with, because there's no blockage, there's no suppression or control of the raw sensory input that seems to be coming in to the brain without any control, just full awareness of all the sensory input. Double vision is often experienced as well, just because the nerves that surround, or the nerves that control the muscles that surround the eyes, are very delicate and they're very long, and they're also emanating right from the midbrain, where a lot of that torque happens. When you get hit in the head, the midbrain is twisted and turned. It's about the size of your two fingers, and if you take your hands and twist your fingers, that's a lot of pressure on that midbrain, and those nerves in that area are controlling the eyes. We have 12 cranial nerves, the ones that are incredibly responsible for all life functioning. And of those 12 cranial nerves, 3 of them are dedicated to the extraocular muscles of the eyes. So 25% of all these cranial nerves are there for one purpose, primarily to control the movement of the eyes. And when they're out of synchrony, the eyes will drift out of alignment and you'll see double vision. And you'll certainly have difficulty tracking when you read and tracking your visual environment, which makes things very stressful. It can cause people to have extreme anxiety, because when you're in a novel environment, what enables us to feel comfortable and confident and safe in a novel environment is our eye movements that are scanning the environment around us, enabling us to establish a map, a consistent, reliable visual map that enables us to negotiate our body through that space. And when we have unreliable input, then we're not secure in our motor output through that space. So, this is what it's often like for people trying to focus close up when they are trying to read. And again, they might be fine in the distance. And if you go to an eye doctor that evaluates distance vision only and looks for 20/20, they're not going to see this. But when you look close up and you try to endure close focus, this is oftentimes what it looks like. And it's these individuals are highly misunderstood because they see clearly in the distance. So other difficulties, like I've mentioned, have to do with confusion and disorientation, but also headaches and just general nausea. And the nausea is typically coming from this lack of synchrony between the visual system and the vestibular system. The vestibular system and the visual system are so highly linked that they really should be considered one system. They're separated anatomically and they're separated to some degree functionally, but they're serving the same purpose, and that is to enable the body to be secure in space, to move through space, and to feel, to have visually guided movement through that domain of gravity that we're all living in. Also, you've heard of brain fog, of course, and slow processing speeds, slow visual endurance. These are areas where it's very difficult for clinicians to grasp the significance of these symptoms for their patients. And oftentimes they are thought to be malingering, or they're thought to be exaggerating their symptoms. But brain fog, some of you might have had COVID, and some of you might have had like COVID fog from this, or prolonged COVID. And so many of these symptoms are very similar to that for processing speed and clarity and fluency, verbal fluency, the ability to be amongst other people in a social situation, being able to talk back and forth and keep up with conversations is extremely difficult for people with slow processing speed and difficulty with visual endurance. Now, the reason for this is axonal shearing, like I mentioned before. So these axons are very thin and very delicate, and when they're stretched or twisted, the functionality of these neurons can be either quickly compromised or compromised over time. So symptoms in the beginning are often the only symptoms one has later on. So later on, symptoms can be developed over time because of this shearing effect, and slow degradation of these pathways can make your concussion worse after a few months than getting better. And so this is where you really want to work on reestablishing the nutritional foundation for neurological recovery and the environmental stimulation that's available, either whether it be through hyperbaric or through visual stimulation in a cautious, controlled, regulated way, can oftentimes reestablish neurological integrity within these systems. Chiropractic neurologists do a lot of work in this area as well. But we have to get into the system, and when the visual system is sending 2/3 of its information of the brain's receptive neurons are coming in through the eyes, if we can influence the visual input, we can really significantly influence the neurological recovery. So this is where, a quick assessment, an assessment as soon as possible after a concussion gives us a strong baseline, and then we can see how things are going over time with quick and immediate treatment of the visual system, and along with others in your team, whoever you go to for your concussion should establish a team of people right away, which I think should be a nutritionist, possibly a psychologist, chiropractic neurologist, possibly occupational therapy, possibly speech and language therapy, and ensure that there's a nurturing team of recovery, not just monitoring status, because you can really reestablish functions better if you do it sooner. One of the things that we do in vision rehabilitation is we use yoked prisms. Yoked prisms are influencing the visual system in a very dramatic way. And I've got a video here that I'll show you of an individual who has significant difficulty visually guiding his movement as it connects with his vestibular system. I'll show you a before and then an after with yoked prisms. So you're going to first watch this individual walk down the hall, and you'll see that he has some difficulty. And then you'll see him walk again with yoked prisms on, and you'll see that there's an immediate shift of function. So let's take a look at that first video.
Then come on back. Very good.
So you can see there's a lot of apprehension and there's insecurity in the spatial negotiation of that hallway. So now we put yoke prisms on him, prisms that shift the visual spatial input to the brain, and you'll see how he does. So these lenses, they don't have a prescription in them. They're not compensating for nearsightedness or farsightedness or astigmatism. They are simply shifting the visual space. They're condensing space on one side, they're expanding space on another side, and that relative difference between the spatial input reestablishes a balance in the brain that was originally out of sync. I want to show you another video of a colleague of mine who took a nice video of his patient who sustained a concussion and the treatment that followed as well. So this is about a 2-minute video. So let's take a look at that.
Okay. Now I want you to stop for me. And I want you to slowly turn around. Mom's going to go to your right again in case you go. And slowly walk back towards the door for me.
I'm sorry, I'm going to back up and show you this again. I want you to watch the skater in the middle of the ice and then watch this again. You can see he's leaning to his right quite a bit. And so this is the spatial compression problem that he has. Now, when we put on prisms, you'll see that listing to the right is going to be significantly resolved. So yoke prisms, they shift the space, they condense space on one side and expand it on the other.
How does that feel? Better? Yep.
And then we also do vision therapy. So this is after several sessions of vision therapy with no glasses, no yoked prisms.
Do you feel like you're leaning there a little bit? Maybe just a little bit. Turn around there and just walk back to the picture again. Perfect.
So there's other ways that we treat concussion as well, and that is with tinted lenses. Tinted lenses oftentimes help resolve the incredible amount of photophobia and oftentimes difficulty with migraines or headaches that are involved with the overwhelming input from the environment in regards to light and flicker and movement. We also do vision therapy. As you can see, this policeman was hit over the head with a beer mug in a brawl, and he's coming in for vision therapy as well. It's something that you can learn to overcome if you drive input into the neurology of the brain. You can drive recovery. And so this is what it's all about, is to be proactive, to engage the system in the activities it wants to recapture control over. And it's just a guided therapeutic process that enables this to occur in vision therapy. So I'm going to end the presentation right here in order to have anyone ask any questions about anything that they have in regards to vision and concussion. There's our phone number in our office. Also, I want to let you know too, if you are seeking out there might be people in different parts of the country, the Neuro-Optometric Rehabilitation Association. So that's the Neuro-Optometric Rehabilitation Association is the professional team that provides really good information and does great work on the ability to treat and to examine individuals with concussion. Also, the College of Optometrists and Vision Development is also a very good group to consult with. So they too can give you good insights and good clinical evaluations for anyone that has had a concussion.